Okay, I think we should start so that we end on time. I'm Marissa. I'm a clinical fellow at the moment in respiratory medicine, and I'm joined by my co-host, Logan, two of the three co-founders of Medicine The Essentials, and we will be covering the OSCE Masterclass session number 11 on communication and psychiatry. I'm just admitting one more. So just in terms of a brief background, so the aim of today is to give you tips and tricks on communication type stations, as well as psychiatric OSCE stations, as well as allow you to practice a few scenarios. I think we only actually have one practice scenario in the session. We tried to cover as much as we could in the 1.5 hours. A few housekeeping rules. All burning questions are welcome at any point. You can just put them in the chat. And we will have a dedicated Q&A session at the end. In terms of feedback, we really urge you all to complete the feedback, as this helps us identify areas we can improve upon, and as well as content we should have included, which we can include in future talks. When you complete the feedback form, you will also be able to receive a certificate of stating that you attended this teaching, and then you will also be invited to all our future events. One more note is that we will be recording this for YouTube. So if any of you don't want to be recorded, you can just send me a message in the chat, but we will be recording this for upload onto YouTube. I think Logan will just put in the chat the feedback link so that all of you have it. Yes, he's put it in now. Okay, so I'll be covering common communication stations, and then Logan will be covering an approach to psychiatric type stations. So just in terms of a brief overview of the station types you could be faced with in your clinical exams. So you could get a dedicated history-taking station. Another group of stations or scenarios are difficult encounters with patients. So for example, you could get, you have to talk to an angry relative, break bad news to someone, discuss palliative or end-of-life care scenarios. You could also get a scenario where you have to explain a procedure, such as endoscopy to a patient, or explain their blood results to them. And then another common one is communicating with other healthcare professionals. So for example, giving a referral or a handover to a colleague. You could also get a station on counseling on HIV testing or contraceptives, as well as lifestyle changes, which would include, included in lifestyle changes could be counseling of a patient who's overweight, or counseling a patient who needs to stop smoking, or who would like to stop smoking. And then finally, it's important to remember the ethical scenarios. I don't think we've covered any in this talk today, but we might include them in future talks. But it's important to just take note of confidentiality, assessing capacity, and knowing the elements of how to assess capacity, as well as domestic violence. So before we start with the actual station types, there are a few general tips that I think you should all bear in mind. So for all the scenarios in terms of communication, as well as just general OSCE stations, keep all your answers patient-centered. So always check in with the patient about what they would like to know, how much they'd like to know, and whether they've understood what you've said. And by keeping everything patient-centered, it just shows the examiner that you have good interpersonal skills. So for example, if you suggest a treatment, ask them how they feel about it, what are their thoughts and feelings. And then another important, or one of the most important factors to showcase, is that you can listen actively. So active listening is actually something you just need to practice. I'm sure all of you are able to do it, but it's basically when someone says something to you, when the patient says something to you, you need to acknowledge certain aspects of what they say, and repeat that back to them so that they understand that you've listened and understood what they've said. And then, of course, we need to show our empathy. And finally, you also need to all remember that this is, in most OSCE scenarios, it might be a normal person and not a patient per se. So it might be a person with a script or dialogue. So they might be actually trying to lead you somewhere. So if they're trying to lead you down a different train of questioning, try and think about why they could be leading you down that path, and don't just disregard what they're saying, because they actually are given a script and are told around about what to say or what the end diagnosis is, basically. So other communication tips for all these stations, as a general principle, you should start with gathering information. So you start with really open-ended questions, and then once you gain a good understanding of the type of condition they're leading you towards, you can go to closed-ended or more specific questions. It's also important to avoid jargon. So jargon is just any technical terms, avoid them altogether. Again, this shows that you're patient-centered, and you're really thinking about making things as easy as possible for the patient to understand. Another aspect is to think laterally about management. I know most of you are medical students, so you wouldn't be asked to know very detailed management, but also just think about common things first, and general things. It's not all about medication. So for example, mention that if a patient is coming to you with an increased body mass index, BMI, mention exercise and other changes before going on to drastic things like medication or bariatric surgery, for example. So these are a few of the communication stations we will be focusing on today. So we'll go through history taking, breaking bad news, an approach to the upset or angry relative, explaining a procedure, handover, counseling, and then finally difficult conversations. In terms of the history taking station, I mean, you just basically need to know a bit about every condition, because it really could be anything. There could be anything that's the presenting complaint. But it's essential to remember to start with open-ended questions, as I've said before, and then go to closed-ended questions. Just a reminder that the actor does have a script. So listen to everything they're saying. I know sometimes you can get nervous and you have a question in mind, but actually you need to go along with what the actor or patient is telling you. Also, it's important that you take one question at a time. And I think one of the key things is to not interrupt the patient. This also shows that you're actively listening, you're being patient-centered, and you're letting them express what they need to. Another important thing is to remember red flags. So to always ask about red flags. So for example, if a patient is coming in with coughing up blood, remember to ask about constitutional symptoms like loss of weight, loss of appetite, family history of cancer. So for each condition, remember the red flags. And then also remember signposting. So remember to always advise patients that, you know, if X happens, or if you feel more short of breath in a patient who's coming in coughing and feeling unwell, then always this is where you can find information. Or if you feel really unwell, you can call 111 if you think that it's safe for them to go home. And then finally, summarize and plan. In your plan, you also need to make sure that the patient is happy with the plan and that they agree to the plan. Otherwise, if it's just a one-sided plan coming from you, the patient might not follow the treatment, or might never present back to your practice, or for example. And then finally, safety netting. So always just advise them on danger signs if they're getting worse for specific, or what those features, symptoms would be if they're getting worse, and where they could seek help. Okay, so moving now to breaking bad news, which is quite an important station and probably you'll probably all come across it in some form of medical school exam. I like to use the SPIKES protocol. Remember that it's a good tool, but not a rule. So the SPIKE stands for setting, perception, invitation, knowledge, emotions and empathy, and then finally summary and plan. In terms of setting, in the exam scenario, I don't think you should really move too much of the furniture. If you want, you can set your chairs at a 45-degree angle, which is the recommended, or just make sure you're facing the patient. And then make sure that not just for exam purposes, but in clinical scenarios, that you're in a confidential area if you're going to be discussing sensitive issues. And in terms of perception, so this is where you need to glean what the patient knows so far and what their expectations are. So you could say something like, could you please explain what has happened so far, so that you can get an understanding of what the patient has gone through in terms of the investigations and what they understand by these investigations. So for example, if a patient has had an enlarged prostate and they've had a biopsy, so you could ask them, to explain what has happened so far, and then they can talk you through all the different things that have happened. And then you could ask them, what do they think is the problem, for example. And then in terms of invitation, this is where you check if the patient wants to know their result right now, or if they would like to wait until there's a family member present. Also, just this shows that you're being patient-centered and thinking about what the patient wants. And then if they're happy to go ahead and for you to give them the result, you could say something like, I have some important information to tell you. Are you sure you wouldn't like anyone to be in here with you when you receive the information? And then you could move on to knowledge. So this is where you actually give the information, but always remember to fire a warning shot. So that's something like, unfortunately, I don't have such good news for you. And remember to always chunk and check. So give them little bits of information and not just, don't give them too much information at once. So the chunking and checking works, for example, like you give them a little bit of information and then ask, what do you understand by this? And then give them more information. A good way to do this could be if you say, so as you know, Mrs. X, we did a test called a biopsy last week, and unfortunately the results have not come back as we'd hoped. Then you can, it's a good idea to pause here and then just give them some time to think and reflect. And then once you see that the patient looks as if they want to know more, you can ask, can we keep going? Or would you like someone, again, ask, would you like someone to be here with you? And then you can carry on into the actual diagnosis. And then in terms of emotions and empathy, it's also important to just, like I said, allow pauses. And demonstrating empathy is, you need to also be careful of this. So because demonstrating empathy is not saying, I understand what you're going through, because actually 99% of the time you don't understand what they're going through. But you could say something like, it's understandable to feel shocked or to feel scared, or I can see that you look anxious. So just acknowledging that you are able to notice and recognize their feelings, and just show that you're there for them. So make sure that the patient knows that you're there to support them, and if there's anything they need or any further information, how you can get a hold of yourself or colleagues. And then finally, to summarize and plan. So just make sure finally that the patient understands what you've explained. So you could ask them to explain in their own words what you've discussed today. And in terms of a plan going forward, just think about a follow-up, and then also ways they could contact you and offer support. And also offer, an important thing is to offer the patient to offer for them to bring back their family member or organize a second consultation to bring their family, so you could also explain the diagnosis to their family. Okay, so that was quite a lot. We're moving on to the angry or upset patient. So this is quite similar to breaking bad news in that it's a similar process of collecting data, so collecting information about what has happened, what has made the patient or relative angry or upset, and then managing the issue. So acknowledging that a mistake did happen, apologizing for whatever happened, and then in terms of actually acting, coming up with how you can resolve this issue and also prevent future issues. For the angry or upset patient, it's important to allow them to express themselves, so get all their anger out. It's also important not to deflect or try and blame other people. So for example, you shouldn't say, well, I wasn't there when the medication error happened, and I'm sure it was a nurse's fault or something like that. You should be working as a team. So basically own the mistake as if you had done it. Just apologize on behalf of the team instead of trying to blame a specific person. And then also reflect and acknowledge their feelings. So similar to the breaking bad news scenario, never say that you understand what they're going through, but you could say something like, it is understandable to be frustrated. You've been through quite a difficult time. And then always in the exam scenario and also in real life, maintain eye contact with the patient. And then remember that it's okay to say sorry and apologize. And then finally, like I mentioned earlier, think about what you could do for the error or whatever has made the patient upset. Think about what you could do right now, as well as reassure them about what you will do to prevent this issue from happening in the future. And then finally, agree on a plan and make sure that the patient or relative is happy with this plan. And then make sure that they understand the action points that you'll both be taking away from the scenario. So just to highlight a few important points, don't argue or disagree with the patient or relative. This is very important. This could be basically pass or fail in the exam. Don't deflect and say it wasn't you or blame a specific person. Offer for the patient or relative to speak to senior colleagues, set up follow-up meetings, and mention how you would prevent this from happening in the future. So you could mention that we're going to fill out an incident form and have a meeting with the ward team to prevent this from happening in the future. And you can also direct the patient to PALS. Okay, so I've done quite a lot of talking. We have a scenario here. I don't know if any of you want to try it. Anyone, you can just unmute yourselves.
Sure, I think I can give it a go.
Okay, go for it. So I'll just read it quickly. Oh, sorry, for the person who's asked what's PALS, PALS is Patient Advice and Liaison Services. There's a PALS office at every hospital. Yeah, so I'm just going to read the scenario for everyone. You're a junior doctor on the gastro ward. Mrs. Smith was given 8 milligrams of warfarin instead of 5 milligrams. Her relative is very upset. Please speak to her relative about the situation.
Okay, so my name is Steven. I'm one of the junior doctors on the ward. So can I just confirm that this is Mrs. Smith's relative?
Yes, I'm Mrs. Smith's relative. My name is Anne.
Okay, so and I understand that you're quite upset today because the wrong dosage of blood thinner was given to your relative. Uh, can I find out what has happened or what you understand from the situation?
I just don't understand how you can be so incompetent when you gave my mother so much more warfarin. Don't you know warfarin is dangerous?
Mm. First of all, I just want to say that I'm really sorry that that has happened. And I understand that it must have been a very upsetting situation for you and your mother to go through. It is important for patients to get the right dosage of the medication, and therefore it is important that this doesn't happen in the future again. At the moment, is there anything you would like us to do for your mother?
Well, I want to know what you're going to do about her being given the wrong dose.
Right, okay. So if I could just explain what I'll do moving forward. At the moment, I've informed one of my colleagues who would administer another medication to make sure that the warfarin is not overly delivered, meaning that we'll reverse some of the side effects of giving an over dose of the warfarin. In order to prevent this from happening in the future, I would also fill up an incident form, making sure that all of my colleagues are informed about this incident and that this would not happen again in the future. Is there anything else that you like to discuss or raise?
Uh, well, do you know why she was given 8 milligrams and not 5?
Mm, unfortunately, I don't know why this has happened, but as I said, I'm really sorry that this has happened, and it is very unfortunate. And I'll do everything to the best of my ability to make sure that this would not happen again in the future. If you like to, I'll also be able to arrange a meeting for you with one of our senior colleagues or one of the consultants on the ward to discuss what to be done in the future. Is that something that you like to do?
Yes, that's something I'd like to do. But I just want to ask, how are we going to check that, she's not overdosing on warfarin, that she doesn't start bleeding from her eyes?
Yes, understand that you have this concern, and it is important for us to know that she's not suffering from any overdose. I've also informed my colleague about the whole situation, and she would be given a full, thorough examination, and also we'll check through all the prescriptions and all the drugs that have been given to her to make sure that she's not suffering from any side effects of it. Yes, and what something else, what another thing that you could possibly do is also to contact the patient advice and liaison service to lodge a complaint if you wish to, and perhaps they could also offer us some advice and also help us give us some feedback on how to improve from this situation.
Okay, thank you. Okay, I think we'll pause that. I'll just go through what I had written down. So firstly, I think you did a good job. So I think what you could have improved upon a little bit is collecting more information about who I was. I know I mentioned I'm her mother, but you should have asked about the relationship more, and my understanding of why she's on warfarin and a bit more, gone into that a bit more. But I think overall it was really well done. You reassured me and acknowledged my concerns well. You didn't shift any blame. You didn't interrupt me. So we'll just go through what I had put down here. So we went through the concerns. So you'd ask them, please, can you go through the concerns you have regarding the care of your mother? Listen actively by acknowledging and reflecting what you did. So you could say something like, I can hear this has been very frustrating for you, and that you must have felt really helpless because you obviously can't be with your mom all the time while she's in hospital. And then this is something we couldn't really do over Zoom, but make sure you are making eye contact. You can use hand gestures if you want to, it's not a must. And then give them a chance to speak, which I think you did really well. You didn't interrupt me at all. And you did ask if I had any questions. In terms of management, I think you did well to acknowledge my concerns and you did reassure me. Something you could have mentioned is that you would check my my mother's INR level and make sure they're in the correct range. You did apologize. And then in terms of ACT, I think you did really well. You mentioned that you discussed with seniors. You would also report it as an incident, and you offered to give me the contact details for PALS. And then we sort of came to an agreement at the end because I agreed with everything you said. Yeah, I think you were quite supportive. Just at the beginning, one point is just to collect more information about the relationship and my understanding of why my mother's in hospital, but otherwise well done. Okay, so we're moving on to explaining a procedure. So for this type of scenario, really couldn't be any procedure. I think I have an example later on about explaining how to use an inhaler. So we'll go through that. But firstly, avoid jargon or any medical technical terms. Be systematic, but try and come up with your own approach. What I like to do is just go from, I cover the following in this order. So the indication, so inform the patient about the indication for the procedure. So is this a curative procedure or is it diagnostic? So by this, I mean, are you removing a tumor or are you performing a biopsy? Is there going to be any benefit to the patient's symptoms, or is it just purely to diagnose a condition? And then describe the process of what will actually happen on the day, the risks of the procedure, as well as the benefits, what preparation the patient will need to do. For example, if they're doing a colonoscopy, whether they need to take bowel prep before and the timing of all of this. Then finally, the aftercare. So what they need to do afterwards, if there is anything, and then if there is an alternate procedure, if the patient isn't happy with this procedure, you could also just mention that. Yep. So we're moving on to referral or handover. So this is something I like to use, the S-bar technique. So S stands for situation, B, background, A, assessment, and R is recommendation. So in terms of situation, this is when you explain or describe your situation. So I am Yurisa, I'm the nurse on ward X. I'm calling about patient Y, and I'm concerned because their blood pressure is low, they're tachycardic, their temperature is, they're pyrexial, and their news score is 5 or whatever it is. And then give a brief background. So here you don't really want to go into the complete past medical history of the patient, just all the important points. So if, for example, this patient was admitted on this date with a chest infection, they've had X, Y, and Z done. They've now deteriorated over the last 24 hours. And normally they are alert and currently they're drowsy and confused. So just a bit of background, just the important points. And then moving on to A, which is the assessment. So mention what you think your top differential is, and then the management you have given. And then also ask if there's anything else the person you're referring to would add, or anything else you should do. And then finally, yeah, so this is more recommendation. mention what exactly you need the person you're referring to, what you need their help with. So for example, I need you to please come and review this patient because I think he or she has pneumonia. And then it's also important, like I said before, to just ask them about any other management you could do in the interim while they come down. So this is just a tool, it's not a rule. Once you become more familiar with referring patients, it will just become really easy and you'll know exactly what to say. But when you're starting out, it's a good tool. Yeah, so just other key information you should always include. So your name, your grade. So are you a SHO? Are you a registrar? What department you're calling from? So if you're calling from medicine or from A&E, the reason for calling, and always just be polite and ask, is it an okay time to talk? Because you never know if the other person is really busy and they might say, can you call me back in 5 minutes? Can you call me back in 10 minutes? But in the actual exam, this is unlikely to happen. And then, like I said before, make it short and sweet. A summary of what you've done and the management, just the most important points. And then it's always important just to ask who you're talking to. So just ask for the other doctor's name. And then, yeah, finally, just ask if there's anything else you should have done or anything they would change. So now we're moving on to counseling. So this is just general counseling advice. So this is called the 5 stages of change. Let me just get the pointer out. Can you guys see that? I'll probably see it now. The 5 stages of change. So we start with pre-contemplation, which is, so just a bit of background before I go into the actual stages. This is just a way you can look at where along the change pathway your patient is. So if they're at the pre-contemplation phase of change, it means that they are not currently considering change. So it's basically they basically ignorant and are not aware that there's anything they need to change. And then in contemplation, the patient is basically aware that they need to make a change, but they're ambivalent about this change. So they're sitting on the fence. And basically your advice is going to help push them over into actually motivating them to start and make that change. In terms of preparation, in this phase, some people have had experience with change, but they couldn't maintain this change, basically. And then in terms of action, this is if your patient is currently practicing a new behavior for 3 to 6 months. And then maintenance is just making sure that they get past the 6 months and continue this new behavior. This is just a way I like to think about it, because there are a few techniques for each of the stages. So if they're in the pre-contemplation phase where they actually have never considered change, you could validate their lack of readiness. This is a good technique to use. So say that, I understand that you've never thought about this change, and it can be quite daunting to make a change, but use this type of approach to try and get them to consider changing. And then here you can also just encourage them to explore their lifestyle and think about the risks involved, for example, with smoking. In the contemplation phase, you can also, again, validate their lack of readiness to make a change, but also discuss the pros and cons of behavior change. And then in preparation, you can help them identify problems they had in the past, so why they didn't sustain their change, what hurdles they had, and come up with ways to avoid these hurdles in the future. And then in terms of the action phase, you can just support them more and offer more social support and try and just be their cheerleader, basically, to get them into the maintenance phase. And then in the maintenance phase, you should just plan for follow-ups, even if they have gotten past that 6-month point. And then also discuss coping with relapse, because that can be quite devastating for a patient. Yeah. So basically, in counseling station general tips. So you need to look at the reason for their current behavior. You don't have to use the 5 stages of change every single time. It just helps me think about where my patient is in their change process. Because often you'd find most people are in the pre-contemplation phase. They didn't even know that their BMI was high and they needed to make a change. Next, you need to look at the patient's readiness to change. So what are possible motivating factors for change? So could it reduce the amount of money they spend if they stop buying cigarettes? Or is it going to improve their health? So improve their COPD, for example, with reference to the smoking scenario. And then also look at what they've tried before, what worked, what didn't work, and also why. Because you don't want to be trying to suggest things that didn't work well for them in the past. And then try and make it patient-centered again. So ask them what they would like to try this time, if they would like more information about other options, other techniques. And then importantly, I think it's a real eye-opener when you go through the pros and cons of a specific behavior. So for example, smoking, go through what they find beneficial about smoking, and then go through all the negatives. First, ask them what they know about what negatives they're aware of smoking, and then go through additional ones that you think are important. And then also just think widely. Is someone saying something? No, okay, no. Think widely about support. So think about referring the patient to support groups, other specialists, and a multidisciplinary team. For example, in a patient who is obese and needs to lose weight, your multidisciplinary team could include a dietitian, depending on how high their BMI is. It could be an endocrinologist. It could also be, well, you basically will encourage them to exercise. Yeah, so quite a few people involved. And then finally come up with a plan and make sure that the patient is happy with this plan, and schedule follow-ups to look at their progress and encourage them. Okay, so now we're moving on to smoking cessation. So basically counseling. There's also another approach you could use, which is specific to smoking. You could really use it for anything, but this framework was developed with smoking in mind. So it's called the 5 A's. So they stand for ask, assess, advise, assist, and arrange. So in terms of ask, so it's where you would gather information like all the other stations we've gone through. So what would your patient like to know? Then assess, so assess their readiness. So where are they in those 5 steps? Are they ready to quit smoking? And then ICE just stands for exploring their ideas, concerns, and expectations from you. And then, like I said, explore their previous attempts at stopping, what worked, what didn't work, explore their smoking history, when they started, how many they smoke a day, relevant past medical history. So for example, if they've got hypertension and diabetes and are really a vasculopath, then you could use that to your advantage by explaining that smoking is just going to worsen their arterial disease. and then other concomitant substance use. And then the third A is advice. So tailor everything to what the patient would like to know and the level of detail to how much they want to know. You shouldn't be sitting there and just preaching to them, but making sure that this is information they want to know, and making sure that they understand what you've said, and that you make sure you've addressed any of their questions. In terms of assist, so there's another framework, which is the STAR framework. So this is quite specific to smoking. So you set a quit date. So you and the patient can come up with this together. So for example, next month on the 20th of May, that's your quit date. And then we'll schedule a follow-up the week after and see how you've done. Encourage them to tell their family, friends, colleagues about quitting, because I think when you involve more support, there are more people to look out for you and also be in your corner as a cheerleader. And then in terms of the A, it's anticipate challenges and brainstorm ways to overcome them. So for example, if the patient's entire group of friends smokes, you need to come up with something, how the patient will actually manage this type of scenario when all their friends, when they get together with their friends and all their friends are smoking, what will they do to avoid the urge to smoke? And then R is just removing tobacco products from the surroundings, and then avoid smoking areas. And then finally, arrange, follow-up and safety net. So always arrange a follow-up, safety net in terms of if anything goes wrong or if they need help, that they could schedule an appointment with you. And yeah. Okay, I think we've gone over this quite a lot. Yeah, just to mention that in terms of general support, something you could mention is that there's an NHS Stop Smoking service that you could refer them to. And then in terms of medical treatment, you could discuss nicotine replacement or medication if this has failed in the past. And then, yeah, always just come up with a plan together. Okay. So we're just going to go through counseling on a flu vaccine. So you might get a scenario where you have someone coming in who is a bit ambivalent about whether or not they should get the flu vaccine. So the way to start the scenario is to elicit what their concerns are about receiving the flu vaccine. Is it just specifically the flu vaccine they're concerned about, or is it just vaccines in general? And then also just try and elicit what misconceptions they have. Also be mindful when you respond. Don't try and impose your opinion onto them, and be respectful of their opinion, because you don't want to alienate the patient, and they'll probably never get a vaccine after that. And then again, elicit their readiness. Where are they in those 5 stages? And what would they like to know about the flu vaccine? Because they've come to you for help, so there must be something. You need to find out what the expectation of today's consultation is. So what do they want to get out of this? Is it that they just want more information because they're thinking about getting the vaccine? So you can discuss the pros and cons. So for example, you're less likely to get the flu, and if you do get the flu, there'll likely be mild symptoms. People might be asking, now in the current climate, would I get coronavirus? Then you could explain that the flu vaccine and the COVID-19 vaccine are 2 completely different vaccines, and the flu vaccine will not protect you against coronavirus. In terms of the cons, so there could be some local pain, they could have a low-grade fever and feel a little bit unwell, and have muscle aches, but it will resolve within a few days. It's important to also ask about allergies, because an absolute contraindication is an egg allergy. And then it's important that also you remember that it's safe to take in pregnant women and children who are more than 6 months old. And then finally, with all the stations, come up with a plan together, because maybe they don't want the vaccine today and they're going to think about it. So arrange a follow-up when you could check up on them. Okay, so you're just going to go through inhaler technique. Before I give you all the answers, can anyone go through how you would explain inhaler technique to a patient? Anyone, it's fine, even if you're wrong.
I can go again if no one wants to.
Okay.
So firstly, I'll start with information gathering, asking why patients are on the inhalers and what type of inhaler that they are using at the moment.
Mm-hmm.
Then I would check patients' current understanding of inhaler technique, how they have used it in the past, and whether that was effective.
Mm-hmm.
Then after that, I would probably demonstrate how to use the inhaler. So starting from checking the expiry date, checking that it's the right inhaler, and going through the steps with them from shaking the inhaler first to holding their breath once they inhale the medication inside. Then after that, perhaps we'll check their understanding and whether they are following,
Mm-hmm.
and whether they have any other questions
Mm-hmm.
that they would like to ask. I didn't sort of say too much about the inhaler technique, but I'll go through with them in greater detail, with the actual station.
Okay. Okay, yeah, that's fine. I think that was good. Like you said, you didn't go through the actual technique because it's something you need to do, hands-on. But yeah, so you covered the first point, elicit which inhalers the patient is on, explore their technique, also explore their understanding of what an inhaler is. So why are you using it? Explore what their understanding is first, then explain what it's actually meant to be for. Because you'll notice there's a lot of misconceptions about inhalers. And then in terms of the correct technique, so like you said, check the expiry date, shake the inhaler well, remove the cap and ensure the mouthpiece is clean. You can encourage them to stand or sit in an upright position. They should also hold the inhaler upright. So a common technique would be to put the index finger on the top and the thumb and your middle finger on the sides to support the inhaler, and then remind them to breathe out completely, and then seal them out, breathe out completely just before, seal them out well around the mouthpiece, and then simultaneously press on the top of the canister and breathe in deeply and slowly. They should then hold their breath for 10 seconds and then breathe out slowly. It also reminds the patient that if they're still feeling short of breath and they're using the reliever, the blue pump, then they can take another, they can use the inhaler again. But if it's the regular brown preventer, it's generally use two pumps a day. But it depends on how much the patient is taking. So also just elicit all of that at the beginning. And then finally, remind them to replace the cap and ensure the mouthpiece is clean for their next use. You could also advise them that you can remove, let me just get the pointer out again. You can remove the actual pump from the mouthpiece part, and you can then wash this part in lukewarm soapy water and just let it dry. So it's very easy. It pulls off very easily. Let it dry completely, just to prevent any bacteria building up in the mouthpiece. And then another important thing that people always forget is remind the patient to or tell them, because they might not even know about this, to rinse their mouth. Sorry, there's an A missing here. So rinse their mouth to prevent candida or thrush. And then once you've explained all of this to them, ask them to then demonstrate to you so that you can actually see whether they're doing the correct thing. And then importantly, safety net at the end, and advise them to go to A&E or call 111 if they're still feeling short of breath after using the reliever appropriately. So this is generally, blue is generally the reliever and brown generally the preventer. But remember, again, in the exam, just read what the pump says. And then difficult discussions, which we're not really going to go into, but things you should prepare for the exam would be end-of-life discussions or palliative care, organ donation, just know a little bit about that. Refusing life-saving treatment. So in this case, you would need to assess capacity. Speaking to a colleague about inappropriate behavior. This is very common. So for example, if you find your colleague has been smelling of alcohol and showing up late to work, you need to discuss this. And you asked in the scenario to discuss this with them. And then discharge against medical advice. A family member asks you for information about the patient. So you need to remember confidentiality, make sure that the patient themselves is happy for you to share information with the family and the level of detail of information the patient would like to be shared. And then consent and capacity in a child who is less than 16 years old. So this is referring to Gillick competence and the Fraser guidelines. You should know about those two. And then finally, non-accidental injury. So a scenario could be a child keeps on coming in, or an infant keeps on coming in with bruises or different ages of fractures on X-ray. So you just need to think about non-accidental injury there. And I think this is the final slide before Logan speaks. So in terms of palliative care, just to touch on it briefly. So elicit what condition your patient has, whereabouts in the palliative care journey are they? Have they just been diagnosed with a palliative condition, or are they at end of life care already? In terms of biopsychosocial management, always look at their symptoms and managing the symptoms, but also don't forget about the psychological and the social aspects. So how are they feeling? Are there any symptoms of depression? In terms of social, look at their support, their religious beliefs, and how you could just help them or support them through by looking at all three aspects. And then elicit their fears, ideas, concerns, and expectations, and then involve a multidisciplinary team and their family. And then finally, make sure there are longer term plans in place. So, and check if there's an advanced directive or a DNAR. Okay, so I think now Logan is going to talk. We'll be covering psychiatry. I'm not sure if you want a 5-minute break. Those who want to break can put in the chat.
Hi, everyone. Yeah, no break. Is everyone happy to continue? Please continue. Eurissa, have I got control of this?
Do you?
No.
No, you don't.
Do you mind fast forwarding whenever I mention? Is that okay?
That's fine.
Oh, brilliant. Hi, everyone. My name's Logan. I'm one of the co-founders of Medicine's the Essentials. I usually work in A&E, but I have done a psychiatry SHO job. Has anyone had any experience of psychiatry? What sort of level are you guys at? Have you spoken to psychiatric patients or patients who present to A&E that have a psychiatric presentation? Can you just comment in the chat? Years 4, currently in psych placement. Anyone else? I'm going to done psych placement. And Year 4, brilliant. And what did everyone think about their psych placement? Certainly, whenever I did mine in my year 3, I was quite anxious. It was very different to what I was used to. We were learning all about the cardiovascular system, respiratory system, and psychiatry is definitely very different to what I've been learning about in textbooks. I don't know if anyone agrees with that. Somebody saying yes, observation. Taking a history took longer. Yep, so that's a big difference. Longer time with fewer patients and much more detailed histories. Yeah, so typically you get a lot more time, I would say, with psychiatric patients or within a psychiatry environment to really delve a bit deeper into why they've come in, more about their background, and build sort of a rational picture of what their kind of differential diagnosis is and what their plan is going forward. So yeah, it's a really good job. I would definitely recommend it if you guys go into your foundation training. It's a certain, I learned an awful lot, and I would definitely recommend it. Could you go to the next slide, please, Sursa? Thank you. So I thought we'd just talk about a few of the different types of psychiatric presentations, including how to take a history, depression, mania, perhaps going over suicide risk, and schizophrenia as well as a presentation, and also just to finish doing the mental state exam. So it would be quite hopefully interactive and hopefully useful for you. So the if you just go back, Larissa, sorry. Thank you. So the ICD-10 is an international classification of diseases. It's sort of incorporated into sort of all clinical practice. The WHO has created this for all physical ailments and psychiatric ailments, and there are quite a few sort of sub-preferences, what's the word, sort of groups of psychiatric presentations. And I think that the 4 main ones that I've kind of categorized here. So anxiety and obsessive compulsive disorders, and that includes things as OCD, seasonal affective disorder, post-traumatic stress disorder, panic attacks, agoraphobia. Another important one is psychotic disorders, so patients who present with psychosis, schizophrenia. Then there's other disorders that are precipitated by substance misuse, so drugs and alcohol intoxication. And then finally, mood disorders, so depression, patients who present with mania, bipolar mood disorder. As well as that, there are some sort of crossover groups as well up at the top there. So neurocognitive disorders such as dementia, Parkinson, Alzheimer's, vascular dementia. There's a whole group of patients that may present with a psychotic type presentation, but it could be precipitation of a dementia or a delirium. As well as that, there are other further subcategories such as learning disabilities, eating disorders. It goes into quite a lot of detail, and I would recommend all of you just to have a little look online to get an idea of what it covers. Let's go to the next slide, please, Larissa. Thank you. Yeah, so how to take a psychiatric history. As someone's mentioned already in the chat, they can be quite detailed. You have to take your time. You have to really, basically what Larissa has said previously, take your time with the patient, really listen to them, observe as much as possible, and comment on literally everything that they do, say, how they're presenting to you. And if it's a first presentation of psychosis, for example, or depression, low mood, high mood, in mania, you want to get the presenting complaints. The first thing you do is ask what has brought you in today, or why are you here today? And some patients will have insight to why they're here, or why they're in the clinic, or why they're in A&E, but others may not. So it might be quite difficult. And then what I would usually do is get a history of your presenting complaint. And if does everyone know the mnemonic Socrates? So I would always get sort of a Socrates mnemonic in there. So if the issue is low mood, I would say, when did it start, the onset, how they feel, the character, is there anything that makes it better or anything that makes it worse, the timing of the symptoms, how long they last for, are there any exacerbating factors that cause these symptoms, and the severity of the symptom out of 10. That's what I would usually do. And you want to comment on features of psychosis, depression, mania, so comment on their mood, if they've got insight to their presentation. And then finally, you want to do a risk assessment. So are they a harm to themselves or to others? Have they come in with self-harm? Have they come in with a suicidal attempt? It's really important to get to the bottom of all that. Past medical history. So patients that present with psychiatric presentations throughout a range of ages, from young patients to very elderly patients. So it's really important to get all the comorbidities in and their current medication. If they're on antidepressants or any antipsychotics, it's really useful to know that. And if they've had any past psychiatric input, if they presented previously with suicide intention or self-harm, or if they've had any hospital admissions, or if they've ever previously been sectioned under the Mental Health Act. So that's also really important. Family history is really, really useful. So a recent, so for example, in schizophrenia, I looked up a recent 2017 study showed that if one twin is diagnosed with schizophrenia, the second twin, there's a 79 to 80% chance that the other twin could be diagnosed with schizophrenia. So there is a genetic element and component to psychiatric illness as well. Social history, again, super important. So any substance use, alcohol, illicit drugs, their social circumstances, if they are in, if they have no fixed abode, if they're in hostels, if they're at home, they have a good support group at home, if they have a family at home. Any childhood history is also quite important, if they've had any previous significant life events. Forensic history, if they've ever been in trouble with the police, or as well as this, any pre-morbid personality traits such as obsessional components to their personality, to kind of give you an idea of obsessive compulsive disorder. Great, so go to the next one, please, Melissa. Thank you. I was going to ask everyone here, it didn't come up, it's meant to be blank, but what the core depressive symptoms. So this is really important in any sort of psychiatric history, especially in a depression history. Depression can only be diagnosed if they have, I think, 2 of the 3 core symptoms. So low mood, you would ask, how is your mood? Loss of interest, anhedonia, do you still enjoy things you used to? Or do they have a lack of energy? Do you find yourself being more tired than normal? So those 3 things can be diagnostic of depression. And depression can be mild, moderate, or severe. Go to the next slide, please, Larissa. Thank you. Biological symptoms of depression. So depression can present atypically or with other symptoms other than the core symptoms that we've just discussed. Usually sleep is affected. Patients will have early morning waking, so they will get up early and they'll find it really difficult to get back to sleep. Conversely, they might be really tired throughout the day. So it's really important to get sleep pattern of your patients. Reduced appetite. So typically patients will have a reduced appetite if they're low in mood, but atypical presentations can mean that patients may have an increased appetite. They may be overeating or emotionally eating. Again, with weight loss, typically patients who are depressed will have lower weight or weight loss because of less eating. But if it's an atypical presentation, then they might have weight gain, for example. Constipation, so if they're not eating, if they're eating fast food, for example, they may become constipated. And a big one is loss of libido. So if they are not interested in sexual engagement, then that's quite indicative of low mood. Next. Cognitive symptoms of depression. So patients can feel really worthless, and you have to kind of get an idea of how they see themselves against others. Do they think that they are worthless? Do they think that sort of life is worth living? And that you should ask them how they think others see themselves. They may have really low self-esteem, so you can ask, how do you feel about yourself recently? And memory and concentration can also be affected quite significantly as well. So patients who are usually depressed have really poor memory and they can't concentrate on something. So they may not be able to read a book from beginning to end or watch a TV show, for example. So it's really important to ask this as well. Patients can be quite fearful, quite agitated. All of these things you need to just get an idea of to kind of make a final differential diagnosis. So it's good to ask all of that. Thanks, Yosef. Yeah. To kind of summarize what we just discussed, I think that this is a really good mnemonic. So SAW email. So it kind of covers everything we've discussed. Sleep disturbance, reduced appetite, weight loss, energy, mood, both low, anhedonia, which is loss of sort of loss of interest to things, irritability, and libido loss. I think it's really important to also exclude organic causes. So in practice, when you guys all are in hospital and you're doing a referral to psychiatry, say you're working in A&E, the first thing the psychiatry team will ask, have you ruled out an organic cause? So it's really important to do blood tests on these patients. Infection can cause confusion, especially in older patients. Urinary tract infections are a real big cause of sort of a delirium. Also, it's really important to elicit if they've had any substance or alcohol misuse, or if they've had any significant life events recently, so such as a bereavement. So that could be a triggering factor of why they presented. Cheers, Ursa. Next slide. Thank you. So suicide risk assessment. So I thought we could just go through this quite quickly. So you're an SHO in the psychiatry ward. You can ask to assess a new admission, Sarah, a 21-year-old female who has recently attempted suicide. Please assess Sarah and come up with a management plan. So before we go on to the next thing, the next slide, could you just comment in the chat what you would be looking for, sort of risk factors for suicide, if anyone wants to have a go. Previous attempts, risk factors for suicide. Yeah. So Stephen, that's really good. Yeah, previous attempts is definitely a big risk factor. Anyone else? Family, friend, support network. Yeah. Guilt, plans. They were planning. Family history. Yeah, all really good, guys. Well done. Yeah, so organized planning is a huge thing. So if somebody has left a suicide note, if they have got all their orders in affair, for example, someone who's written a will, yeah, sort of future planning, further planning is really good. A really high risk feature. How did she get to hospital? Did someone find her? Yeah, exactly. So if she was found under a bridge, for example, that's a huge risk factor versus someone who potentially took an overdose at home and then immediately rang the ambulance. Not saying that they're both very serious, but I would say the patient that was found under the bridge is slightly more high risk at further suicidal attempts. Brilliant. If you can go on to the next one, please. So great. So we've farmer and a vet is also a really important one. So farmers are usually they're usually male, they're usually sort of middle-aged, elderly. They're usually quite isolated. Some farmers have access to guns as well. So farmers can definitely a high risk factor into the suicidal attempts. But yeah, this is another mnemonic, sad persons, which is also really useful. So if they are a male, puts them at slightly higher risk. If they are over 40 or under 19, they've had low mood, anhedonia, previous attempts, ethanol / that's meant to be drugs. If they are rationally thinking, so if they are psychotic or if they have capacity, So if a patient is psychotic, it basically means that they don't have insight to what they're doing. They're really high risk. Social isolation, which we've discussed, organized planning, which we've discussed, no hobbies, no job, sort of no sort of future plans is also very high risk. And if they've got chronic illness or chronic pain as well. Yep. So the next one. It's really important if you're clerking someone in, so if you're seeing them taking a history, doing an OSCE, and they've presented with self-harm or suicidal attempt or thoughts of suicide, I would always approach the patient asking them what they decided to do before the incident, during the incident, and after the incident. So I think it's really important to categorize your history like that. So before the incident, for example, if something's happened to them, if they've had a significant life event, if it was planned, what we've discussed before, if it was impulsive, if alcohol or substances were involved, such as illicit substances such as drugs were involved, and if they had actual intent to die. So some patients will have real intent to end their lives. They are really, really high risk. And then during, so I would get a really clear, detailed account of what actually happened, kind of down to the last sort of the last detail. The more detail you get at the front door, the psychiatry team will be very thankful. So did they lock the door? Did they go on high? Did they do it out of sight? As I said, is alcohol involved? Did they leave a note? That's also an important one as well. And then what they did after. So did they immediately call for help? Did they immediately tell someone, say for example, if someone took an overdose, or did they present because they were found outside under a bridge, like we've mentioned before? So it's all of these things are really, really important to elicit. And again, speaking about the psychiatric history that we've already discussed, talking about past medical history, drug history, social history, all of that, it's really useful to get. Some factors for suicide, basically. So predisposing factors for suicide. So if patients have come from long-term adversity or any childhood trauma, that gives them a predisposing factor, puts them at higher risk of suicide. Poor support network as well. So if someone comes in and out of care, for example, that would put them at a higher risk of self-harm and suicide. Precipitating factors. So as we've mentioned, acute stressful life events. Poor compliance with medication, for example, if they're already on an antidepressant or antipsychotic, and then perpetuating factors. So if they have insight or not, if they've drank any alcohol, substance misuse, or if they've not been able to solve any of their predisposing adversity, as we've already discussed. The next couple of presentations I will chat about is mania. I wanted to ask, has anyone seen someone who's presented with a manic episode in their psychiatric placement, psychiatric placement? We've got one. Stephen said yes. Do you mind mentioning in the chat, Stephen, how they presented, but make it anonymous, please? Yep, impulsive behavior. Make it generalize it as well. Flight of ideas. Yep. Exactly. So pressured speech, that's a really good one. So pressured speech is someone's talking and not really coming up for air, and they feel like there's a pressure for them to just blurt out as much information as possible. And the definition is basically a period of persistently elevated or irritable mood, and it must last for about a week. And this again is a really good mnemonic just to cover all the bases of someone who presents with mania. So if their mood is elevated, if they're really excited or really enthusiastic, if their activities increase, if they're naughty, so if they've gone on a massive spending spree, if they're taking lots of drugs and alcohol, if they've been really frivolous and slept with lots of people as well, if they can't sleep, and if they've got lots and lots of confidence, couldn't sit still. Katie, yeah, that's another good one. So quite irritable and can't really sit still. Thanks, Eurosep. Okay, so before you click Eurosep, just on the left-hand side here, guys, what do you think this is demonstrating on the left-hand side? And what do you think is being demonstrated on the right-hand side? If I say, so someone's saying perception, yeah, that's good. Illusion and perception. Grandiosity, yeah, all really good guesses. So if I say it's a fixed belief, I'm talking about the left-hand side. Oh, yours is let the cat out of the bag, as it were. So delusion is a fixed belief. So as you can see, this little cat here thinks that they are a massive lion or a tiger. So it's essentially a fixed belief. And on the right-hand side is a hallucination, so the perception in the absence of a stimulus. And hallucinations can be visual, they can be gustatory, so taste, or they can be olfactory and smell as well. Someone mentioned an illusion. What is an illusion? Does anyone know what an illusion is? I don't have it on the slides here. So Sidra, okay, what does that mean? So are they not fixed? So an illusion is a misperception. So it's essentially like seeing something in the shadows. For example, you see a shape in the shadows. So it's a misperception. It's you see something different to what it actually is, if that makes sense. Brilliant. Okay, so schizophrenia. So schizophrenia is quite a complex presentation, and it's a combination of quite a few different symptoms and signs. But these are the sort of 3 or 4 different the primary ones that encompass schizophrenia, and I've just kept delusion and hallucination up in the top right to kind of remind us of what they are. So in terms of delusions, somebody presents with certain delusions, so you can ask them, do they feel like anyone's out to get them? So if they're persecutory. Delusions of references, so if they're seeing or believe that there are any messages for them in the newspaper, for example, or the television, but they're specifically for them. If they have delusions of grandeur, so do you have any superpowers? Do you think you're royalty? Do you think, yeah, you're Superman, Superwoman, super whatever? Delusions of passivity as well. So do you ever think that you're not in control of your thoughts or actions? So those are also quite useful to ask the patient. And as we've mentioned, hallucinations can be auditory. So if you ever heard anything when no one is actually there, do you understand, if you do hear voices, do you understand the voices? Are they talking about you? Are they talking to you? Are they telling you to do anything? Are they telling you to hurt yourself or hurt others? And then visual, olfactory, and gustatory. So have you ever smelled, tasted, or seen anything that you couldn't explain? And then also thoughts. So schizophrenia, people with schizophrenia will have potential thought pathology. So thought insertion. So do you think that there are ideas placed into your head that are not your own? Thought withdrawal. So if you think your thoughts are taken away, or thought broadcasting. Do you think other people can hear your thoughts being broadcast? And these are the first rank symptoms of schizophrenia, essentially. So thought interference, what we've discussed, auditory hallucinations, delusional perception, and delusion of control. So a false belief that an outside force has control over your thoughts. Delusional perception, so what have I put here? I have a letter from the Prime Minister to ask me to build a castle. So they think that they have been given an important task to fulfill by someone who is in a position of power, basically. Just finally, just a couple more slides, guys. You've been really patient. Thank you. The mental state exam. So this is probably something that you will be asked to do in your OSCEs. I was asked to take a history and do a mental state exam and then present my findings. I think it's really important is take a good psychiatric history, as you would any history, but leave a bit of time to present to the examiner as well. So because you want to kind of link the history to your mental state findings, and then come up with a differential diagnosis. If you want to go forward, Lisa. Brilliant. And there are lots of different mnemonics for mental state examination. I think ABC Smiths is really useful. I'll put it in the comments after, because this is the last slide. So A for appearance, B for behavior, C is for cognition, S is for speech, M mood, I is insight, T is thoughts, H is hallucinations, and S at the very end directly covers suicide, so suicidal thoughts or self-harm. And I think what you want to do is literally comment, as I said before, comment on absolutely everything, what they're doing, what the patient is doing, what they're saying, how they're acting, their speech. Is it, does it make sense to you? Is it tangential? Is it quick? Is it slow? I think mood and affect should always mention what sort of the patient's subjective mood is. So they could say, I feel really low, but actually objectively they have good eye contact, their speech is of normal rate, rhythm, and tone, and there's normal content. So their subjective perception of their mood does not match the objectivity of their mood. So that's quite useful. In terms of their thoughts, so as I've said, you wanted to mention, are they coherent? Are they making sense? Are they talking about random things? Are they having abnormal thoughts or thoughts that would be abnormal to myself and you? And then all the other things that we've discussed about. So did they think people are against them? Do they think they've got had their thoughts interfered with? Are their thoughts being broadcast? You also have to comment on insight. So do they think that they need help? Are they willing to accept help? Do they think that there is a change in their mental health? Usually, whenever I did my third year psychiatric placement, a lot of patients have very little insights, which makes them a danger to themselves and potentially others. And that's why they needed, that was a sort of a factor of why they were admitted under the Mental Health Act. Fine. I think I've got one more. I think this is the summary, and this is Eurissa's slide. But yeah, keep it simple. Be yourself. Just another day at work. Don't be afraid to admit that you're unsure, and practice, practice, practice. One thing that I did in my OSCEs is that I deflected blame and got marked down. So just, yeah, apology is not an admission of guilt, what Eurissa said, and an apology can certainly get you out of a tricky spot and really could diffuse a situation. So I think that's really useful going forward. I wish I knew that whenever I was in my third year. Any questions at all?
So I've just put the feedback form in the chat. Sorry, I had the YouTube one earlier. So the first link is the feedback form. You'll get your certificate of attendance in the next few days. I think we have automated them, so you should get it automatically actually. And then link to our YouTube channel. Someone asked earlier if when we would upload today's presentation. It will probably be in the next 2 days. Would you just do the state exam at the end to the examiner? Yeah, so the mental state exam, you wouldn't say it as if you're saying it to the patient, but you would be gathering, while you're talking to the patient, you'd be gathering all the information and then present to the examiner at the end once you've thanked the patient. So you wouldn't be saying it to the patient directly, no. Any other questions? just a reminder that if you complete the feedback form, you will get a certificate of attendance, and then you will be able to access our future talks. Because we run free sessions, we have been oversubscribed. So for this session, we had about almost 300 people who tried to sign up, but unfortunately Zoom only lets 100 enter. So if you do complete the feedback form, we will allow you access to future OSCE sessions. No problem. If you guys think of any questions, you can also just drop us an email. Yeah, so we have, although we have the professional version of Zoom, I think we don't, I'm not sure why, but it's capped at 100 for us because we, yeah.